We've made great strides nationally in terms of the impact that study and the work with that small group has been able to do, to the point that one of the staunchest anti-advocates of REBOA use now is a medical advisor to the company that makes the catheter. I look at one of the things I'm the proudest of our team for being able to participate in, instead of being 5 or 6 years behind the curve in terms of things that really make a difference in treating our trauma patients, we're actually participating in establishing the curve. So we're putting ourselves years ahead of the average trauma center that takes care of trauma patients by participating in the research. And this is a great example. The REBOA use is a great example of that.
There's a young person that has a shattered spleen and the surgeon is 30 minutes away. The person comes in with a blood pressure of 60 and you have 2 units of blood, because I'd already tracked that out that morning in your hospital. What are you going to do? And their first response was check to see if they're pregnant, because they're going to die. That was their go-to response. They had no further follow-ups at all to that. They would give the blood and they would expect that person to die in the trauma bay. So when I said, what if you could design something that would stop bleeding below the diaphragm, what would it look like? And they eventually, with 5 to 10 minutes of little mini question prompting, came up with similar to what the first generation REBOA was, which was essentially a Foley catheter in somebody's iliac artery going into the aorta. And then we pulled out the catheter and showed them. And there was a couple of the providers were actually crying because they were like so amazed that technology had advanced to a point where they could fix a problem. And so the next steps, obviously, I'm not there enough. I'm here 51 weeks out of the year and there 1 week out of the year, is to have some kind of longitudinal care model there where we can continue to train, because that's not a procedure that you can just do because you want to. And so training and getting things like that into their hands, because they have incredible abilities, they just have no resources or limited resources. Soon, if you are operating independently, operating meaning providing care independently, it's by choice, not because of necessity. With our ability to, like, globalization, but that globalization starts regionally for us. Habersham, Union General, Barrow, Dahlonega, like that Lumpkin, in the mountains of North Carolina. If you're in 2030, probably functioning on your own and just a phone call like we would have done in the 70s, you're probably doing that out of choice, not out of necessity. And so I think we're going to be able to be at the bedside in some functional way, as more of a partner remotely. There's a ton of work that Kyle mentioned in the robot surgery world.
TACS Copilot is utilized for in our hospital system. They have an ambient listening module that doctors can have a conversation with a patient with this ambient listening device, and AI will summarize that conversation into their note. So that's an incredibly valuable, more an efficiency tool. But if you think about what patients really want out of their interaction with their physician, they don't want to see you typing into a screen and looking over your shoulder to ask them questions. They want to see this. They want to see you sitting down and really engaging in that conversation. But we've been really slow to find an application for that. One of the things I'm really excited about is working with our AI partners, and we have great IT folks here at this facility as well. How do we make ourselves in the trauma bay more efficient? You know, one of the things we struggle with is documentation in that fast-paced, chaotic 15 or 20 minutes in the trauma bay where we're doing 100 different things and there's 20 people and they're yelling things out, all of which is an important piece of information to document in real time. How can we really jump off of our technology and get those pieces of information logged without having one person having to take notes and write on their arm and write on their scrubs and put little sticky notes here and sticky notes there, and then go try to find the time an hour later to go back and put that all in the electronic medical record so that we can know how we did and how we can do it better next time. In the public, the perception is, well, a level 1 trauma center is different than a level 2. And that's partially true, but really from the clinical care perspective and the requirements to be a level 2 and a level 1, if you look at the what we call the Bible of trauma centers, the clinical requirements are exactly the same. All of the critical elements are for level 1 and level 2 providers. The only difference is residency education and research. And so, uh, for us to step up and become a level 1 trauma center and a level 2 is just it just shows the community dedication that we want to train surgeons to stay in our area and provide great care, so that their kids and grandkids can get even better care than they've received.